Morning. It's 9. We'll start. We have assembled here to have a fantastic webinar on recent advances in pharmacotherapy of cardiovascular system. These recent advances are always, what to say, pharmacology needs to be updated every semester wise. Yesterday it was a trending message in many pharmacology HODs group, many pharmacologist groups, that a question paper has been repeated from 2017 to 2021. Yesterday's question paper was same question paper which was given on 2017 also. Everybody was discussing it was right, good, bad, and all. But the question may be the same, but the answer will be definitely different after 4 years. So it's a pharmacology is ever, what to say, rapidly updating subject. So it's better to have always recent trends on cardiovascular pharmacology. So even especially in the area of cardiac failure, so many new interventions, drug interventions have been emerged. So today we are happy to have our speaker, Dr. Tirunavukarasu with us. And formally, I start this program with the formal welcoming by Dr. Emma.
Good morning, sir. Good morning, everyone. On behalf of Department of Pharmacology, Annapurna Medical College and Hospital, it gives me an immense pleasure to welcome all of you who has meticulously registered and have taken time away from your busy schedule to attend this webinar today with us. It is my privilege to welcome our guest speaker, Professor Dr. J. Tirunavukarasu, sir, Head of the Department, Pharmacology, Savitha Medical College and Hospitals, who has accepted our invitation in a very short notice and has joined us here to give an enthusiastic speech on recent advances on pharmacotherapy of cardiovascular disorders. I would also like to extend a warm welcome to our dignitaries, Honorable Chairman, Mr. J. Satish Kumar, sir, Dean, Professor Dr. P. Shanmugam, sir, Medical Superintendent, Professor Dr. N. Mohan, sir, Vice Principal and Head of the Department Microbiology, Professor Dr. D. Usha ma'am, and Deputy Medical Superintendent, Professor Dr. N. Prasanna Babu, sir, Controller of Examiner, Professor Dr. P. M. Subramanian, sir, Director of Academics, Professor Dr. Danasegar, sir, and today's chairperson, Professor Dr. K. Vijay Babu, sir. And I once again welcome all the participants, medical fraternities, and students to join this enthusiastic seminar, webinar, and enjoy the session. Thank you.
So now I call upon Dr. Dinesh Babu, our assistant professor, to introduce our speaker.
Thank you, sir. It's an honor to introduce Professor Dr. J. Tirunavukarasu, sir, Head and Department of Pharmacology, Savitha Medical College, Chennai. Sir has finished his undergraduate from KMC, Chennai, and post-graduation from Stanley Medical College, Chennai. He is an eminent teacher and a great academician. He is teaching the UG students for 17 years and PG students for 14 years. And sir had got a Best Faculty Award in Savitha University for 4 times. And he had done many research papers and published many articles both in national and international journals. And is very good at teaching the PG aspirant by making the concept simple and understandable. And he's been working in various reputed institutes like DAMS, SPEED. Sir is a star speaker in Aspire program conducted every year by SRML, Chennai, where the PG students throughout the India waits for his lecture, and he guided many PhD students and postgraduate students to achieve the best thing in life. He is a member of Institutional Human Ethical Committee, Savitha Medical College. Apart from his career, the academic career, the hidden side of Professor Dr. Tirunavukarasu is he's a fantastic Tamil poet and a great orator. Once again, I thank Dr. Vijay Babu sir for giving this opportunity. Thank you, sir.
Morning. I now give the stage to the sir So he'll be enlightening us with this fantastic speech. Thank you. So it's yours.
Yes, sir. Thank you, sir. Protable, very good morning. Thank you for offering me a very good opportunity to share my small knowledge with you people. So thank you for the opportunity. So without wasting time, sorry, only 1 hour and 55 minutes and then some doubts. So like that within the given time, finish about recent advances in cardiovascular pharmacology. So without wasting time, I think I go for topic proper, sir. So just sharing the slide.
Thanks.
Yeah.
See, I want to present this webinar like a movie. My movie name is Recent Advances in Pharmacotherapy of Cardiovascular Disorder. So this movie, action, everything will be there. So enjoy the next 2 hours with the recent advances in cardiovascular pharmacology. My movie starts.
Sir, why? Background BG. Music.
Okay, sir. With this basic introduction, I'm going to start my session. So first topic I'm going to cover is anti-anginal agents. We start. Okay. I think the crowd maximally undergraduates and also postgraduate and my dear colleagues and faculty members are there, I think. So to start, we know there are 3 different types of angina, namely stable angina, and then we having unstable angina. One more thing, vasospastic angina. Here the patient going to complaining of chest pain only on exertion. When he take rest, the pain is completely getting relieved. It's called stable angina. Unstable mean here the patient going to have complaining, sir, I don't know when I am going to develop pain. Even on resting stage, I am developing pain. That's called unstable. It's most dangerous. At any time, this patient may land on acute MI, very dangerous. Another one thing called vasospastic angina. Look here, the coronary artery was absolutely normal. There is no atherosclerosis obstruction, but still sudden vasoconstriction causing coronary problem, causing chest pain. That's called vasospastic angina, also called variant angina or Prince metal angina. Now, what is the most important pathology here? Whenever age advances due to diabetes or hypertension or hypercholesterol or obesity like this, there's going to be atherosclerosis deposit occur in the coronary artery that causes reduction of oxygen supply. So one of the main factor that causing reduction of oxygen supplies due to obstruction. This obstruction, this reduction of blood supply may be enough when the patient is taking rest. But the same patient, when they go for walking or jogging or when they do exercise, the heart rate is becoming very high. When the heart rate is becoming high, the workload is increases. When workload increases, oxygen demand increases. When oxygen demand increases, there going to be problem of angina. So, angina can be due to either reduction of oxygen supply or due to increasing oxygen demand. So, to treat this problem, what we can do? Either we can increase oxygen supply or we have to decrease oxygen demand. For that, To increase oxygen supply, I need vasodilator. And to decrease oxygen demand, I need cardiac depression. I want cardiac depression. So fundamentally, an anti-angiogenic drug can be either vasodilator or cardiac depression. When you say vasodilator, there are two important group of drugs. One group of drug called nitrates, another group of drug called potassium channel opener. Now, undergraduate, very important question. There are a lot of examples are there for potassium opener, but you should know the one and only potassium opener useful for treatment of angina, maybe nicotindil. Remember nicotindil. There are a lot of other drugs like hydralazine, minoxidil, diazoxide. They're all useful for hypertension. So one and only potassium opener useful for treatment of angina, nicotindil. Coming to cardiac depression, we have the most popular drug that's called beta blocker. So very fantastic first line drug for treatment of coronary artery disease. There's another group of drug having vasodilatory action and cardiac depression action that's called calcium channel blocker. So fundamentally, the four most important group of anti-angiogenic drug what we having are nitrates, potassium opener like nicotindil, and then beta blocker and CCB. Other than this, we are also having some recent advances or other drugs. For example, we have something called ivabradine. Very important, ivabradine. What is ivabradine? I'm going to discuss later on. It's very important. And then we have something called trimetazidine ranolazine. These two drugs are called antioxidant. They're useful for angina. So it's an outline of drug useful for angina. Now the point is how these drugs are relieving chest pain. How these drugs are relieving chest pain. For example, we are telling nitrates are useful for treatment angina. We have short acting, long acting, intermittent acting like that. Isosorbidine nitrate, mononitrate, amyl nitrate, NTG like that. How they relieve angina? One mechanism, very important mechanism, nitrates are vasodilator. By dilating the blood vessel, mainly they're dilating venous system. By dilating venous system, they are reducing the preload, but they are also dilating minimally artery, thereby afterload also decrease. By decreasing preload and afterload, cardiac workload decreases, thereby oxygen demand decreases. It is fundamental, very important. Nitrate relieves angina mainly by reducing oxygen demand. But one more point, nitrates are vasodilator. So what happened to the coronary circulation by using nitrate? Here is the important point. Nitrate causes redistribution of blood flow from non-ischemic to ischemic area. This is a very greatest point. Nitrate having the beauty of redistributing the coronary artery from non-ischemic to ischemic area. So by this two-way, nitrates are relieving angina. That's first point. Next, we have another drug called nicotindil. Nicotindil, a vasodilator, it also having nitric oxide releasing property. By dilating the blood vessel, reducing preload, afterload, thereby oxygen demand decreases. Another very important, beta blocker. Beta blockers are reducing heart rates, thereby reducing workload, thereby reducing oxygen demand. And they are very important. Why important? I will discuss within 1 minute. Wait for some time. The very first line drug for treatment of angina. The another group of drug is called CCB, like calcium blocker. They having vasodilatory as well as cardiac depression property. As a vasodilator, increasing oxygen supply to myocardium, as a reducing heart rate, because reducing heart rate, reducing workload, thereby reducing oxygen demand. By the way, CCB are useful for treatment of angina. Another class of drug. We have something called pathway of fatty acid oxidation inhibitors called antioxidant like ranolazine trimetazidine. By controlling the free radical activity, controlling angina. Miscellaneous group of drug. Another drug is ivabradine. Ivabradine actually a funny current sodium channel blocker. It's a funny current sodium channel blocker, thereby reducing impulse formation, reducing heart rate, thereby useful for treatment angina. Then one more important new drug, malsudomin. Malsudomin, a latest drug having nitric oxide releasing property. It's a longer acting agent useful for prophylaxis of angina. So in here, what I'm telling is outline and summary. How majority of anti-angial drugs works. What is the mechanism of action of various anti-angial agent? It is a fundamental. Now I go in depth. For example, since undergraduates there, what are the points you should know regarding nitrates? Okay. Nitrates actually acting on cysteine receptor. By acting on cysteine receptor, they cause release of nitric oxide. Look here. Whenever there's a release of nitric oxide, this causes activation of guanyl cyclase enzyme. By activating guanyl cyclase, they're going to accumulate second messenger cycle GMP. This is important. UGs, please important. The second messenger getting accumulated by using nitrates or CGMP. They are having vasodilatory property. That is smooth muscle relaxing property. When I say smooth muscle, I mean vascular smooth muscle and visceral smooth muscle. By the way, muscles getting relaxed. That way, vasodilatation going to occur. That's the mechanism action. Here, since pages are there, I want to tell some extra point. Now, extra point. Here, I want to interact with you people. Come on, either undergraduate or postgraduate. Whoever knows the answer, can you please interact with me? The question is, look here. I told nitrates are acting on cysteine receptor, causing release of nitric oxide. This nitric oxide activating guanyl cyclase, thereby causing vasodilatation. My question goes to all my dear students. My question, look here. Can you please answer? There are some drugs without the help of nitric oxide directly activating guanyl cyclase. They call nitric oxide independent direct guanyl cyclase activator. Anybody, either undergraduate or postgraduate, if you tell the answer, you are superb in pharmacology. Can you please answer? Name some direct guanyl cyclase activator without the help of. Yes, very good. Somebody answering. Riociguat, fantastic. Roll number 834, fantastic. We have something called Riociguat, sinosiguat. Good, very good, man. Very fantastic. I never expected. Good. So Riociguat, sinosiguats are direct guanyl cyclase activator useful for treatment of primary pulmonary hypertension. In this, good. Devikala, fantastic, ma'am. Now, since you told the basic, I want to talk about recent point. The recent advances, similar to Riociguat, sinosiguat, we have one more newer drug called Vericiguat. It's a latest drug. This drug got approval for treatment of congestive cardiac failure. Please note, Vericiguat. It's the latest direct guanyl cyclase activator having vasodilatory action useful for treatment of CCM. Okay. Another very important point I want to tell you. Look here. Nitrates are acting on cysteine, causing release of nitric oxide. Look here. This nitric oxide acting by accumulating cycle GMP. Here I want to tell one super important clinical point. Look here. Cyclic GMP, we know vasodilatory activity, but the cyclic GMP normally undergo metabolism by PD5 enzyme. That is, cyclic GMP undergo inactivation by PD5. That means my question. If I want to have vasodilatory action, I have to accumulate cyclic GMP. So for accumulating cyclic GMP, I have to inhibit PD5. Who are the selective PD5 blocker? Can you please answer, undergraduate? Very simple question. The selective PD5 blockers are, can you please answer? That's called sildenafil, tadalafil, verdenafil. Yes, again, Dr. Devikala, very good. So Del answering, very good. So sildenafil, tadalafil, verdenafil are selective PD5 blocker. They're going to cause accumulated cyclic GMP, thereby causing vasodilatation. They're useful for treatment of primary pulmonary hypertension and for treatment of erectile dysfunction. So this is one extra point. Another extra point, you should know this point. And third extra point, I want to tell you the extra point. Look here. Nitrates are acting on cysteine receptor. Now look at the basic. Whenever I give nitrate continuously, for example, if I deliver the nitrate through IV infusion, or if I deliver through transdermal route, continuously, when the receptor exposing to nitrate continuously means the receptor undergo down regulation. Now tell me, when the receptor undergo down regulation, whatever nitrate I'm giving, my nitrate may not produce response. That means my nitrate developing one problem. What is the problem? That's called development of tolerance. Very important. nitrates may develop tolerance. One of the problem we facing with the nitrates are development of tolerance that is due to down regulation receptor. Okay. And then this problem occur when you give continuously. For example, when you deliver the intravenous infusion or by using transdermal patch. So this slide I prepared to discuss new point, that is riociguat, chinosiguat, useful for treatment of pulmonary hypertension. Vericiguat, a latest drug useful for treatment of congestive cardiac failure. Next point. For basic, nitrate as a smooth muscle relaxant, as a vasodilator in cardiology useful for treatment of angina, MI and heart failure. Whereas non-cardiac use, very important, as a smooth muscle relaxant, they can be useful for treatment of biliary colic pain and for achalasia cardia. Biliary colic pain, achalasia cardia. One more point, actually very important, nitrate also useful for treatment of cyanide poisoning. Here one important question. What property of nitrate useful for treatment of cyanide poisoning? The answer is nitrate going to form one thing. Come on, Devigala, can you please answer? Nitrate acting by forming one thing that is useful for treatment of cyanide poisoning. That is called formation of methemoglobinemia. Nitrate forms methemoglobinemia. By the way, useful for treatment of cyanide poisoning. Okay. And coming to adverse effect, nitrate, the most common problem as a vasodilator causing headache problem is the most common. Another very important clinical point you should know, nitrate as a vasodilator causes hypotension. Hypotension. Whenever hypotension, to compensate the low BP, reflexively sympathetic system activated. The reflex sympathetic activation causes tachycardia. So it causes hypotension with the reflex tachycardia. Here, what is the fundamental? The reflex tachycardia is due to what mechanism? The answer is reflex sympathetic activation that causing reflex tachycardia. Why I am telling this point is, look here. Suppose if we give nitrate, if the patient telling, sir, I feel palpitation. Patient on nitrate therapy developing palpitation means it's due to hypotension with reflex tachycardia. Now the question starts. Can you please answer, undergraduate? Nitrate causing hypotension with reflex tachycardia. When reflex tachycardia, they go for palpitation. Now question. To control the palpitation, I'm going to add one drug with the nitrate. What is the drug I'm going to add? To control the palpitation, to control the reflex tachycardia, I'm going to add one drug that's called beta blocker. Very, 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 very important. Very good, ma. Very good. Beta blocker can be added with the nitrate to control reflex tachycardia. This is clinically most important, Other problem, nitrates may develop tolerance due to down regulation on continuous therapy. Other problem, it may cause methemoglobinemia, but this was exploited for treatment of cyanide poisoning, very important. And also, nitrate rarely causes skin rashes problem, like penta, erythrate, or tetra. Nitrate causes skin rash problem. That finishes nitrate. And then this is what practically most important. For example, a patient on nitrate therapy, if the patient want to take sildenafil for treatment of erectile dysfunction, come on, what is the drug interaction between nitrate and sildenafil? Very important question. See, nitrates also acting by accumulating cyclic GMP, and sildenafil also acting by accumulating cyclic GMP. When both are taken together, they cause severe accumulation of cyclic GMP, causing severe systemic vasodilatation that causes severe hypotensive shock, and sudden death can occur. So it's a dangerous problem. Sildenafil and nitrate should never taken together. If the patient want to take sildenafil, there should be gap between this and this drug for about 8 to 10 hour gap should be there. Nitrate and sildenafil should not taken together because of risk of severe hypotensive shock. Practically most important point. Next point, look here. We so far finished one thing called how nitrate useful for angina and the problem. Nicotinidyl, something simple. It's a vasodilator having potassium opening property, nitric acid releasing property, useful for angina. Common problem, hypotension. Sometimes they cause headache and rarely causing aphthous ulcer, oral cavity ulceration. That's called aphthous ulcer. And coming to trimetazine danilazine, both are antioxidant, inhibiting formation of free radical, thereby useful for treatment of angina. Of course, CCB, calcium blockers, are reducing heart rate, like verapamil, diltiazem, reducing heart rate. And they also having vasodilatory property, going to improve oxygen supply, thereby useful for angina. And then Beta blocker, very important. Beta blocker, angina. I mean, you should talk about beta blocker. Very important because the beta blocker having role in angina as well as they have role in MI patient. Look here, what is the role of beta blocker in angina? Look here, whenever I give beta blocker reducing heart rate, reducing force of contraction, thereby reducing workload, thereby reducing oxygen demand. By the way, the beta blockers are a wonderful drug for angina. Other point, whenever there is a vasospastic angina, be careful. Don't use non-selective beta blocker. When I say non-selective beta blocker, I mean blocking beta 1 and beta 2. The non-selective beta blocker, because of blocking beta 2, they may cause vasoconstriction. Thereby, they unsafe in vasospastic angina. This point you must be careful. Non-selective beta blocker is not good for treatment of variant angina. And one more thing for an undergraduate, whenever you start beta blocker, don't stop the drug abruptly. Very important, practically most important. Sudden withdrawal of beta blocker may precipitate angina or arrhythmia. So beta blocker, when you stop main, taper the dose, gradually reduce the dose and then stop. Don't stop abruptly. Very important. Another point, a beta blocker can be given with the nitrates to prevent reflex tachycardia, to prevent palpitation. All these are role of beta blocker in angina. Another very greatest point, you must know point, look here, beta blocker having a very good role in acute myocardial infarction. What is the role? Look here, imagine this patient developed acute MI, acute heart attack. Whenever there's acute MI, there's one thing called fear of death, The fear causes anxiety. The anxiety causing tension. They're causing more release of catecholamine. Catecholamine like adrenaline. Now look here, when there's a more release of adrenaline, already there is MI. When there's adrenaline release, that causes tachycardia. When tachycardia, they're causing more oxygen demand. When more oxygen demand, they can worsen the size of infarction, worsening the size of infarction, extending the zone of infarction. And also, when it's a tachycardia, they may cause more chance of arrhythmia. So, in acute MI, due to fear of death, there's a more release of adrenaline that may cause further worsening of infarction and arrhythmia. My beta blocker able to control the catecholamine activity. By controlling catecholamine, beta blocker reduces the size of infarction. So what is the role in acute MI? They can able to reduce the size of infarction, that is reducing extent of infarction and also having anti-arrhythmic activity. Beta blockers are class 2 anti-arrhythmic, very good drug. So useful for VT and VF, so very life-saving drug. So whenever your patient having coronary artery disease, for him or her, you must put the patient on beta blocker. In their prescription, there should be one drug called beta blocker, should be there. Unless otherwise contraindicated, beta blocker should be there in the prescription of coronary artery disease, okay? Because they're reducing mortality and extending lifespan of the patient. So, according to Goodman-Gilman and also according to CMDT, beta blockers are first-line drug for treatment of coronary artery disease. Very important, okay? And then finally, we move on to next one. That is the latest they call ivabradine. You should know something about ivabradine. Very important. Ivabradine actually a funny current sodium blocker. The funny current are involved in impulse formation. So when you block the channel, they're going to be reduction of impulse formation. Now, what is action? Since the action is reducing impulse formation, they cause bradycardia. Look at name. Ivabradine. As the name mentioned, ivabradine causing bradycardia. Because of reducing heart rate, useful for controlling angina. But this drug was approved for treatment of two things. One is angina. One more thing, useful for heart failure. And another important point for postgraduate, very important. Look here. Usually for controlling the heart rate, we go for beta blocker. But some patient may not able to tolerate beta blocker. In them, the beta blocker causing severe bradycardia. They may not able to tolerate beta blocker. For them, the best alternative will be ivabradine. So beta blocker, if not able to tolerate main, we can put them on ivabradine. Ivabradine also going to control heart rate. And coming to adverse effect, it causes mostly bradycardia. Or other problem on chronic therapy, it may cause visual disturbance in the form of luminous phenomena. Luminous means a brightness. In a restricted area of visual field, there's a brightness, illumination. We call luminous. It's also called phosphine. Phosphine. That's about evaporating, a latest drug for angina. Another one more latest drug is we have malsidomine. Nothing special, only 3 points. This is a newer drug acting by releasing nitric oxide. It's a longer acting agent useful for prophylaxis of angina. That finishes my topic of anti-anginal. Now going for MI. Look at this patient. Here, there is a ST elevation in the ECG on V1, V2, V3. This is called ST elevation MI. Now, what are the drugs useful for treatment of acute infarction? Look here. Whenever there's a ST MI, in MI patient, one of the most important problem, chest pain. So to control the chest pain, I want to give analgesic agent. Here, two things are important. One thing, we can use sublingually nitroglycerin, or we can go for injection morphine. Morphine, a opioid, a very good drug for controlling chest pain due to heart attack. Look here. Here, one question to undergraduate. Come on. If the CNS class was overbid, can you please answer? Opioid, morphine is a wonderful drug for treatment of MI pain. If the portion CNS is over, can you please answer? Which are the opioids? Even though opioids are painkiller, which are the opioids contraindicated for treating MI pain? Can you please answer? Name some opioid. Even though they're having painkilling property, that opioids are contra. Yes, good ma. It's a pethidine and pentazocine. Look here. Pethidine and pentazocine, both of them having the property of causing tachycardia. When they cause tachycardia, there will be more oxygen demand. They worsen the size of infarction. So pethidine, pentazocine, contraindicated. Very good. Liquid, very good. Liquid Gowda, fantastic. Good. Now, after treating pain, now what I should do? Now look here. There is a block in the coronary artery. So I want to control the block. For that, I'm going to start antiplatelet. For example, I go for dual antiplatelet like aspirin with the clopidogrel. I go for aspirin with the clopidogrel. This I will discuss later on. Wait for some time. And then I can plan for recanalization. The recanalization can be done by medical therapy by using thrombolytic agent like streptokinase, urokinase, or we can go for surgical intervention like angioplasty, primary angioplasty called PTCA. Percutaneous transluminal coronary angioplasty, or with the multi-block, I can go for CABG, coronary artery bypass therapy. I can go for and then supportive therapy. I want to go for anticoagulant and cholesterol lowering agent. And if the patient has hypertension, I go for treatment of hypertension, diabetes control. Everything are accessory treatment. Very important. Called outlining the drug therapy useful for MI. Here, one point you should know, man, very important point. I told one thing called ST elevation MI. One more thing here, non-ST elevation MI. Non-ST elevation MI. Here, same treatment except thrombolysis. There are a lot of clinical trial shows thrombolytic therapy not going to give very good benefit on non-ST elevation MI. Here, this causes more problem. So all are useful. PTC useful, anticoagulant, everything, antibiotic, everything, but except thrombolysis. There's only one difference. Come on. So I'm not even. Somebody asked a question. Come on. I've not seen a question. Can you again post? Somebody asked some question has asked. Morphine? I don't understand. I just see the chat box. Suddenly it went off. Can you please repeat? What is the question, ma? Morphine? You asked something. Can you repeat? I'm not able to see the chart. Can you repeat? Or else you keep your question. At the end of the session, I give time for asking doubts. At that time, you please ask doubts. Okay. Whatever doubt you have, please note. At the end of the session, you please ask all the doubts. I will readily explain your doubt. Don't worry. Now look here. All the therapy useful for non-STMI except thrombolysis because this causes more problem. And finally, for postgraduate, I want to tell one interesting point. Look here. When I talk about PTCA, I told, look here. Imagine there's a block in the coronary artery. I want to do PTCA. Even after doing PTCA, to prevent restenosis, I will insert one stent. I will insert one stent. Okay. Now, even after putting stent, there may be chance of restenosis. Can you please answer? To prevent restenosis, in the stent, I am adding some drug, man. Come on, postgraduate, if there, Can you please hands up? There are, yeah, very good, very good. Somebody, sir, Vijay Babu, sir, very fantastic, sir. Even if before my question, the answering very nicely, sir. Too good, sir, creating energy for me. See, we have something called drug-eluting stent, like sirolimus, one more thing, paclitaxel. Look here, sirolimus and paclitaxel stents are there. Sirolimus nothing but it's an immunosuppressant acting by inhibiting mTOR, mucoporin target, mTOR blocker, and this drug causing side effect of immunosuppression, secondary infection, and most importantly, because thrombocytopenia and hypercholesterolemia in the form of high TGL. That's the most important adverse effect of sirolimus. And then paclitaxel, that's an anti-cancer drug, taxane group of drug. This drug causing side effect of peripheral neuropathy and myelosuppression. That finishes my first topic of angina and MI. Okay. Now I move on to my next thing. One more interesting point. Actually, look here. Even though we done PTCA, be careful. Even after doing angioplasty, the patient should be put on dual antiplatelet for about at least 12 months. If possible, extend. So even after angioplasty, even after bypass surgery, the patient should be on antiplatelet. Very important. Usually we go for aspirin with the clopidogrel. P2, what will mean clopidogrel. This I will explain later on. Don't worry. Okay. Next we go on to antiarrhythmic. Okay. Now look here. This is very, very difficult area for undergraduates. Even some junior faculty also find it difficulty when we post for junior faculty to take this class. Sir, antiarrhythmic, I don't want to take, sir, like that. So that's much amount of tough topic. Within 20 minutes, I will make it very simplified version. Okay. Now look here. One of the most toughest job for the cardiologist treating arrhythmia. One of the toughest job for the pharmacologist teaching antiarrhythmic agent. Now look here, how I'm going to discuss antiarrhythmic agent. Look at the basic to high level. The basic is, look here, to understand the regional nuances, to understand the advancement, you should know basic. For basic, I will spend 5 minutes, very worth in attending the 5 minutes, very worth. Look here. Each and every cells of the myocardium are able to form impulse formation. Even though each and every cell forms impulse formation, we know SA node is the pacemaker because majority impulses are rapidly formed SA node. That's why SA node is called pacemaker of the myocardium. Okay. Now, how a cardiac cell going to form impulse formation? How the pulse formed? How the rhythm formed? How arrhythmia occurs? How we are going to treat arrhythmia? That's what my topic. Okay. For that, look here. Usually, when I talk about impulse formation, look, one cell. The cell first taking rest, it's called resting membrane potential, say minus 90 millivolts. In this minus 90 millivolts, the cells are taking rest. Here, nothing can enter into cell. No sodium, no potassium, no calcium, nothing can enter. But the sodium ions are adamantly telling, I want to go, sir. I want to go inside. So when sodium ion repeatedly touching the cell becomes excited thereby. They're going to be going for threshold potential of minus 60. From minus 90, the potential goes minus 60. The minus 60 threshold, when the reaches threshold, suddenly the sodium channel get open. When open, there's a rapid entry of sodium ion. When rapidly sodium entered the cell got excited, thereby rapid firing in the action potential. That's called phase 0. So phase 0 in the action potential corresponding to sodium entry. Very important, sodium entry. Now, within fraction of a second, the curve comes downward. It's called phase 1. Why? Why sudden drop? The sudden drop is due to rapid closure of sodium ionic channel. Rapid closure. Okay. Following the phase 1, look at this. We have one thing called phase 2. Phase 2. Can you help me, somebody from undergraduate? In phase 2, what is the most important ionic channel activity taking place? Can you please help me? Come on. In the phase 2, one most important activity happening is slow entry of calcium ion. Slow entry of calcium ion. Very good, ma. Very good. So slow entry of calcium. Come on. When calcium enter, my doubt starts. Look here. Calcium is a positive ion. When a positive ion goes inside cell, the cell becomes excited. When excited, the curve should go upward. It is not going upward or it's not coming downward. Why? Why it become flat? Because during this stage, not only entry of calcium, there's also efflux of potassium. Efflux of potassium. So the entry of calcium balanced by efflux of potassium, that's why flattening. So phase 2 mean actually practically we say calcium entry. Now concentrate at this stage. Look at this stage, there is a closure of potassium. Sorry, closure of calcium. But still there's a opening of potassium. Because of opening of potassium channel, all the potassium leaking out. That's called efflux of potassium. The efflux of potassium causes repolarization. That causes fall in the curve, reaching the resting membrane potential. So come on, make a summary. In action potential, phase 0 indicate entry of sodium ion. Phase 1 indicate close of sodium ion, and phase 2 indicate entry of calcium ion, and phase 3 mean efflux of potassium and reaching resting membrane potential. Then go for phase 4. It's called diastolic depolarization. Here, what you need to understand pharmacology is, look here, the phase 3 is called repolarization. Where is the depolarization? Look here, 0, 1, up to the middle of the 2. This portion is called depolarization. Phase 3, repolarization. Last one point, look at the gap. This gap is called as action potential duration. So gap is called action potential duration. That means you know the morphology of action potential. If you know this, just take 1 second time. Look at the normal ECG. In normal ECG, we have P, QRS, and T. The P wave indicate atrial contraction. QRS indicate ventricular depolarization, and T indicate ventricular repolarization. That point you know. Okay. Now question. For ventricular activity, for depolarization, we have QRS. For repolarization, we have T. My doubt is, where is the atrial repolarization wave? Atrial repolarization wave is a very slow voltage. It is very small voltage. It is not visible. It is buried under QRS. That's why not visible. Okay, there's explanation. Now you know normal ECG. Now, what I'm going to do is, I'm going to do one wonderful job. This is what you need. For example, I'm going to correlate ECG with the action potential. Now, this is what you need, man. Postgraduate, listen carefully. I'm going to correlate ECG with the action potential. In my correlation, look at the point. In ECG, you know, phase the T wave. T wave is called repolarization. In the action potential, phase 3 is called repolarization. That means my first point, phase 3 corresponding to T wave. Come on, phase 3 corresponding to T wave. If you know this point, come. In phase 3, we are usually telling efflux of potassium. That means phase 3 means we give importance to potassium. That's why. Come on. If there is a serum potassium abnormality, say hypokalemia or hyperkalemia, where serum potassium abnormality, look for change in the T wave. That's the fundamental. Okay. The next important point, look here. In the ECG, we have ST. QRST, it's called ST segment, a flat ST segment. Similarly, in the action potential, look at the flat phase called plateau, phase 2 called plateau. So what book says, the phase 2, come on, the phase 2 corresponding to ST segment. So next one, phase 2 corresponding to ST. Now concentrate in the phase 2, we are mainly dealing with the entry of calcium ion. That's why serum calcium abnormality means look for change in the ST segment. Very important. Hypercalcemia, look for change in ST segment. And finally, one more point, look at in the ECG QRS, the QRS indicate depolarization. I told in the action potential 0, 1 up to the middle of the call depolarization. That means the QRS corresponding to 0, 1. 0, 1 mean mainly we are dealing sodium channel. So serum sodium abnormality can be seen by changes looking in the QRS rate. That's called ECG changes in a electrolyte imbalance case. Electrolyte imbalance and ECG finding. This is basic. Another very interesting point I'm going to tell. Very interesting point I'm going to tell is, look here. When we talk about action potential, I told this gap is called action potential duration. Now, what do you do? Come on. From here, draw one line. If you draw one line, mean that line go and meet on this wave, Q wave. Similarly, draw one more line from here, straight line. When you draw one straight line, this line go and meet on end of the T wave. That means, come on, think. The action potential duration corresponding to QT interval. Note this point. Action potential corresponding to QT interval. Now think. Come on, undergraduate, you can answer. In phase 3, we are dealing with the efflux of potassium. Come on, undergraduates, can you please answer? If the potassium efflux mean the curve will come down, fall, then it's called repulsion. Now my question starts. Look here. If I give potassium channel blocker, come on. If I give potassium blocker, if I am not allowing the efflux of potassium, what happened to this curve? This will fall immediately or it extend and then fall. Can you please answer? Whether fall immediately or fall, extend and then fall. Can you please answer? Yes, it will cause extend and prolongation. Come on. If extend and prolongation, for example, look at my point. Now, look here. It will fall like this. So when I give potassium blocker, if I give potassium blocker, this will extend and fall like this. That means potassium blocker causing prolongation of action potential. Come on, if this is prolonged, they're going to prolongation of QT interval. It is fundamental. So potassium channel blocker may cause QT prolongation. Very important point. Now, among the antiarrhythmic agent, note them, class 1A drug and class 3 drug having potassium blocking property. That's why they cause QT prolongation. Very important. Among the antiarrhythmic agent, class 1A drug and class 3 drug having potassium blocking property causing QT prolongation. That finishes ECG and action potential correlation. Now for undergraduate, one amazing thing I want to tell you, that point is, look here. When I talk about rhythm of the ECG, I am correlating ECG with the action potential. Now come on, undergraduates, look here. When we talk about rhythm, see the QRS mean we correlate with the 0, 1, ST mean with the 2. Phase 2 mean with 3. That mean the rhythm of the ECG depend upon some ionic channel activity. What are ion channel? For example, here sodium channel, here calcium channel, here potassium. So the rhythm of the ECG depends upon 3 important ions: sodium, calcium, potassium. Now go back to ANS. In ANS, you may be studied in the myocardium. We have one important sympathetic receptor. Say beta 1 receptor. The heart rate is also depend upon beta 1 activity. That means, look here, the heart rate and heart rhythm depends mainly on 4 things. The 4 things are beta 1 activity, sodium activity, calcium activity, potassium activity. Now, undergraduate, come on. If there is an abnormal rhythm, that's called arrhythmia. If there's an abnormal arrhythmia, the arrhythmia, it may be due to abnormality of sodium or calcium or potassium or beta. That means you have to mention me. For the treatment arrhythmia, if I want to give anti-arrhythmic agent, mean my drug should be either dash or dash or dash or dash blocker. It should be sodium blocker or beta blocker or calcium blocker or potassium blocker. That's called anti-arrhythmic agents. So anti-arrhythmic agent mean we have class 1 sodium blocker, class 2 beta blocker, class 3 potassium blocker, class 4 calcium blocker. That's what fundamental. Okay. One great cardiologist called Vaughan's William, he classified anti-arrhythmic into 4 classes. Class 1 mean sodium blocker, class 2 mean beta blocker, class 3 mean potassium, class 4 mean calcium blocker. Any drug not fit into the category, they call miscellaneous or unclassified. For example, we have adenosine, atropine, digoxin, and MgSO4, even KCl, all are miscellaneous anti-arrhythmic agents. Only one extra point. The class 1 alone further divided into 1A, 1B, 1C. It's called fundamental. Now, since the crowd is mixed of undergraduate, postgraduate, and faculty members, I want to talk clinically. For example, there are so many types of arrhythmia. Yeah, arrhythmia can be from atrial level or ventricular level. For example, it can be atrial fibrillation or it can be supraventricular tachycardia. It's called atrial level. Or ventricular level means it may be very dangerous, ventricular fibrillation or VT, or it can be a long QT syndrome, or it can be one more thing called the WPW, Wolff-Parkinson-White syndrome. All these are tachyarrhythmias. One more thing called bradyarrhythmias, like that variety of arrhythmias. Now look clinically, another 5 to 7 minutes, we go for therapeutic aspects. For example, look here. In case of atrial fibrillation, what to do? Here, the patient having fast ventricular response. In atrial fibrillation, they have fast ventricular response. So when the ventricular response is very fast, fast ventricular, when the ventricular response fast they are not able to have good amount of cardiac output. So in AF, I want to control the ventricular rate. So for controlling rate, I got some drug called rate controller. So what are the rate controller useful for treatment of atrial fibrillation? That's called beta blocker, CCB like diltiazem and verapamil, and then digoxin. These drugs are acting on AV node, blocking AV conduction, thereby controlling ventricular rates. That's one. But extra one point you should know, there is one more way of treating AF, that is we can reverting the rhythm of AF into normal sinusrhythm. It's called rhythm reversal. What are drugs useful for rhythm reversal? For example, ibutylite, dofetilide, vernaculine, amidone. All these drugs are class 3 drug, class 3 anti-angina. All are potassium blocker that are useful for reverting the rhythm of AF into NSR. That's one thing. But one more thing, there's a way of treatment AF by using DC shock. We can also do DC shock, that is current shock. But one interesting point you should know, when you are planning for DC shock, be careful. In atrial fibrillation, there's more chances of formation of thrombus. So when you go for DC shock, the thrombus get dislodged and going for embolic formation, resulting in stroke. So whenever you go for cardiac shock, DC shock, you have to give anticoagulant. So first thing, rule out thrombus. And if the thrombus, plan for anticoagulation, either using directly acting oral anticoagulant or vitamin K antagonist like warfarin. So anticoagulant must before planning for DC shock. That's about treatment of AF. Next, coming to another important arrhythmia called supraventricular. Look here, supraventricular. Here, the most important point for treating SVT, the drug of choice is always go for adenosine. So fastest acting and shortest acting. This drug is the drug of choice for treatment of supraventricular. Given rapid IV bolus injection. Why is this given rapid bolus injection? This is very, very short acting only for less than 10 seconds. So yeah, ultra short acting anti-arrhythmic agent is adenosine, because the drug is rapidly taken by vascular endothelium and rapidly undergo metabolism by adenosine DMAs. So shortest acting. Now it's about acute SVT. So for a case of acute SVT, drug of choice is adenosine. But one point, the SVT is the one going to come recurrently. So to prevent the recurrence of SVT, we have to plan for prophylactic therapy. So prophylactic therapy means, look here, once again, for acute SVT, I told drug of choice adenosine, but sometimes adenosine in some people causing severe bronchospasm. If adenosine is a problem, then alternative choices, we can go for intravenous verapamil. For acute SVT, either we go for adenosine or verapamil. Theoretically speaking, adenosine is the choice. Alternative choice is verapamil. To prevent the recurrence of SVT, we can put them on prophylactically oral beta blocker or oral verapamil or oral amiodarone. Amiodarone is the class 3 anti-arrhythmic agent. Very important, very important. Okay. Next, another important arrhythmia. Look here. Ventricular fibrillation. Very, very important. Look here. When you are working in ICU, that you are treating case of acute MI patient. When you look at the monitor shows some abnormal rhythm. It's called ventricular premature contraction. It is called VPD. It's called VPD. Ventricular premature contraction. It's called VPC. Ventricular premature contraction. Sometimes, doctor, to VPD or VPC. VPD, we can say either ventricular premature depolarization or we can say VPC. Sometimes two VPD coupled together, it's called bigeminy. It's called bigeminy. Sometimes three VPD coupled together, it's called trigeminy. Now look here. When you are looking at monitor of in MI patient, if the monitor shows bigeminy, be careful. You should trigeminy, very careful, because the trigeminy, like a movie, Gemini, ending in severe acute ventricular fibrillation. Come on, look at this. Look at this. There is undulating QRS, like a snake, bending forward, backward, forward, backward, forward, backward. Only undulating. There's lines are there. There is no typical QRS morphology. It's a pathognomonic feature of ventricular fibrillation. Very important fibrillation. Now look here. In this case, look at the heart. Heart is contracting. Look, contraction, 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 contraction. Look carefully. Look carefully. You're going far. Now, no, going for VF. When they go for VF, they're going to cause cardiac arrest. They cause cardiac arrest, sudden death. So, one of the most important cause of sudden death in MA patient is ventricular fibrillation. VF, okay? Now, look here. In this case, suppose a patient, night 1 o'clock, now a patient shifted to ICU. You are the duty medical officer. When you are checking this patient, pulse will not be there. When you auscultate, even by lip and set auscultation, sound will not be audible. BP may not be recordable. But when you put the patient on monitor shows this pattern of ECG. Look here, there is no flat wave, man. Flat is mean death. But here undulating QRS. That means some electrical activities are there. If the activity is there, it is patient is not dead. Patient not dead. So it's your responsibility to save the patient. That too, within 3 minutes, you have to save the patient. Otherwise, you go for brain death. So within 3 minutes, you want to save me. You alone not sufficient. You call for help. So night 1 o'clock, you're crying for help, crying. Your friend doing duty in OG, surgery, pediatrics, all are rushing. The opening ICU, you are catching nursing hand. Why? Tension, because of tension. So suddenly, your friends want to help you. What? Somebody take care of airway, somebody take care of breathing, somebody take care of circulation. So airway, breathing, circulation taken care, and you are ready for giving DC shock. So look here, when you give DC shock, 260 joules current you are giving, delivering, come on, no response. 260 joules, no response. 300 joules. When you give 300 joules response, sudden shock, there's an unbelievable response, a marvelous response. What? There's a slow appearance of PQRST. Come on, man. Yeah, undulating QRS now become normal in sinus rhythm. When normal, the patient start opening his eyes. At that time, you are going to shed the tears. Why? You are saved the patient, man. You are saved the patient. So the most important procedure choice, for treating VF is DC shock. After that, to prevent the recurrence, we have to put them on a life-saving drug called lignocaine and one more drug called amiodarone. Lignocaine actually a class 1B anti-arrhythmic agent. Amiodarone is class 3 drug. Now, according to ACLS, according to advanced cardiac life support, according to ACLS guideline, currently for treating cardiac arrest that causing VF-VT, a VF-VT causing cardiac arrest means the choice of drug is amiodarone. Very important. Current guideline says, according to advanced cardiac life support guideline, the drug of choice for treatment of VT, VF that causing cardiac arrest means amiodarone. IV is choice. Next option we can go for injection lignocaine. Okay, that's about VT, VF. And coming to one more thing, WP syndrome. Very simple. In WP syndrome, what happened? Look here, there is an abnormal. Actually, look at the myocardium, then it's easy for you. Look here. Normally, everybody are having a SA node, AV node, bundle like this, right bundle, left bundle, Purkinje. In WP, there's Wolff-Parkinson syndrome. Here, one accessory fiber connecting atrium and ventricle. So, in addition to normal conduction, some impulse conduct away this way also, this causing arrhythmia. This is called Wolff-Parkinson-White syndrome arrhythmia. So here the arrhythmia is due to conduction impulse via accessory fiber. So to control this fiber, to control this arrhythmia, the best drugs are we have class 1C drug like flecainide. Class 1C drug like flecainide is very good choice. Alternatively, we can also say, class 3 drug like ibuprofen or class 1A drug like procainamide. But usually what they say, the best drug of choice is flecainide. Now, in this area, I want a super question for all my dear students. Can you please answer either UG or PG? Come on. This is the problem of presence of abnormal fiber. For the arrhythmia, I am using anti-arrhythmic agent like flecainide. Okay, that's okay. But the problem is due to presence of accessory fiber. So can you please answer what is the permanent solution for this patient? Can you please answer, ma'am? Either undergraduate or UG. Yes, good. Ablation of abnormality, radio frequency ablation. Very good, ma'am. Very good. So radio frequency ablation is that permanent procedure for this case. Okay, that finishes treatment for WPW syndrome. Okay, and one more thing, long QT. We talk about long QT called Dorsey dividers here for treating actually class 1A and class 3. I told class 1A drug and class 3, they have potassium blocking property, they may cause long QT. For treating this 2 points, there is something called congenital long QT. For treating congenital long QT, we can go for propranolol, whereas for acute long QT, drug of choice MGSO4. Please note, for treating acquired long QT syndrome, treatment choice is MGSO4. MGSO4 not only useful for arrhythmia, useful for eclampsia, so many other uses there. And for antidote for MGSO4, calcium gluconate. That's also important. Antidote for MGSO4 is calcium gluconate. And finally, one more thing, bradyarrhythmia. See, similar to tachyarrhythmia, we have bradyarrhythmia, simply called sinus bradycardia, something called heart block. Look here. For simple symptomatic sinus bradycardia, we can try atropine. For treating simple symptomatic sinus bradycardia, for that case, we can try atropine. Atropine, we know, anticholinergic agent, thereby acting on myocardium, causing action tachycardia. Because of this action, useful for symptomatic sinus bradycardia. But one more point you should know, the same atropine can also useful for treatment of first degree heart block. Useful for first degree heart block. Come on, actually a heart block can be first degree or second degree or complete heart block. But one thing, the second degree heart block, we have two types. One is called Morbid's type 1, Morbid's type 1 block, and one more thing, Morbid's type 2 block. Like the two important degrees are there. Now, atropine useful only for Morbid's type 1 secondary heart block. Atropine useful for only for Morbid's type 1. That means you finish. Atropine useful for number 1, symptomatic sinus bradycardia. Number 2, first degree heart block. Number 2, Morbid's type 1 second degree heart block. That's all. For a Morbid's type 2 second heart block and for complete heart block, treatment is pacemaker insertion. That finishes important drug useful for treatment of arrhythmia. And remember, doctor, amiodarone is very important drug for undergraduate, postgraduate, even for cardiologists. The cardiac life is around between beta blocker, amiodarone. That's much of important drug. Okay. Anyway, what we done? Various types of arrhythmia and various type of treatment for arrhythmias. Okay, so concept of anti-arrhythmic agent and the therapeutic aspect of anti-arrhythmic. Now the third topic I'm going to discuss is cardiac failure. Okay, so we finished the two most important topic, angina, MI. Now we want to go for cardiac failure. Okay, when I talk about heart failure, two important basic concepts. One thing called acute heart failure, one more thing called chronic heart failure. What is the fundamental aspect you should know? In case of acute heart failure, you should know pathology. When you know the pathology, pharmacology is simple. So what is acute? In acute, as the name indicates, acute, that means rapid, sudden onset of LV dysfunction. Because a sudden LV dysfunction, there's no time to compensate. So sudden LV dysfunction, sudden reduction of cardiac output. When suddenly cardiac output decreases, means there will be congestion of blood in the heart. When this congestion, it ultimately going to cause pulmonary congestion. So resulting in pulmonary edema. So in acute failure, the sudden onset of LV dysfunction, there's no time to compensate the problem. So there's an acute congestion of fluid in the lung, resulting in pulmonary edema. That's the problem. When the pulmonary edema, the patient will present with the breathlessness. So one of the most important clinical symptoms, the patient will present with breathlessness. So how to treat this? So what is the aim? What is the concept? Here, I want to improve output. I want to relieve edema. This is my concept. Okay. So for relieving the edema, I can go for diuretic. For example, loop diuretic like furosemide, wonderful drug, can be useful. Okay, and then To improve the output, I can do two things. Either one thing called ionotropic drug like digoxin, or dopamine or dobutamine, like the ionotropic. They're going to improve cardiac outputs. Or else I go for dilator. When you say dilator, they're going to cause vasodilatation, thereby reducing the preload after load. When the preload after decrease means cardiac workload decrease, thereby I can try to increase cardiac outputs. So dilators. That means the three important Ds. Come on, the three important Ds useful for treatment of acute heart failure includes diuretic, dilator, and inotropic like digoxin, dopamine, dobutamine. That's a fundamental. Here, in acute failure, my aim is to relieve only symptom. Aim is to relieve only symptoms of heart failure. I'm not going to modify the underlying pathology. Here, the patient presenting with breathlessness. So my aim is to relieve breathlessness. That's my aim. Now look at the problem of chronic failure. In chronic failure, what happened? Chronic, as I mean chronic, that means gradual onset of LV dysfunction. Now look at one. When the gradual LV dysfunction means there's a lot of time available to compensate the output. So to compensate the output, that's going to be activation of some compensating mechanism. This is what you need to understand. Look here. When the process is gradual mean, there's a time available for the compensation to occur. What are the compensation coming to play to overcome the failure? One important thing is sympathetic activation, catecholamine, like beta activity, catecholamine activity. One more compensation, very important. Come on, whenever there is a reduction of cardiac output, come on, whenever there's a reduction of cardiac output, the blood supply to kidney decreases. When blood supply, renal blood flow, when blood supply kidney decreases, means the kidney starts releasing renin. That's going to cause activation of RAS, renin angiotensin aldosterone system. So the two important compensatory changes are, one is called catecholamine activity, that is beta activity. Number two, RAS activity. RAS means renin angiotensin aldosterone activity. Now the question, this compensation helpful initially, but when they overcompensate, too much of compensation, come on, when too much of beta activity causing too much of tachycardia and too much of RAS causing angiotensin 2 vasoconstriction, and the RAS may also causing aldosterone, that causing sodium water retention. Look here, because of overcompensation, they're going to increase in heart rate, increase vasoconstriction, and also causing fluid overload. All these causes stress on the ventricle. They cause stress on the myocardium. This resulting in ventricular remodeling. It causes ventricular remodeling. No, now you should know. In chronic failure, the problem is ventricular remodeling. So to prevent the remodeling, I want to modify disease. That means I want some disease modifying agent. I don't want to relieve symptom relief in acute failure. Here I want to modify disease called disease modifying drug. So what are the disease modifying drug useful for chronic failure? When I say disease modifying, I want to attack the beta. That means I want beta blocker, one concept. And then I want to attack RAS. That means renin inhibitor, ACE inhibitor, ARB. One more thing, aldosterone antagonist like spironolactone. So the disease modifying drug. Put the heading: disease modifying drugs are one, beta blocker. Number two, ACE inhibitor. Number three, ARB. Number four, we have MRA. MRA means mineralocorticoid receptor antagonist. Simply called aldosterone receptor antagonist like spironolactone. That's about concept. So remember, in acute failure, I want 3D: dilator, diuretic, digoxin, or dopamine, or dobutamine. Whereas in chronic failure, I want beta blocker. I want RAS pathway blocker like renin blocker, ACE inhibitor, ARB, and aldosterone antagonists. So look at the point. In acute heart failure, as I told, I need diuretic. The most important diuretic, that too diuretic a choice for rapid relief of breathlessness. For rapid relief of breathlessness, IV furosemide. IV furosemide is the drug of choice. Please note, IV furosemide is the drug of choice for treatment of Acute failure, very important. The furosemide having two things. It has vasodilatory action as well as diuretic action. By the way, it relieves symptoms of acute heart failure. One more point, doctor. In acute failure, we can also use morphine. Morphine is a opioid drug. It is also very useful in acute failure because morphine is having histamine releasing property, thereby causing vasodilatation, thereby reducing cardiac workload, as well as causing sedation, thereby relieving anxiety. By sedation, cardiac oxygen demand also getting decreased. By the way, morphine also very good drug for acute failure. That's one thing. Second point, dilator like nitrates or necessary. What is this? I will explain. It's very important new point. I will explain. Wait for some time. Then inotropic like digoxin or dopamine or dopamine. Just a few points. For example, when you talk about inotropic digoxin, here only important 2 points are there. Actually, digoxin in cardiology, useful for two things. One thing, atrial fibrillation. One more thing, useful for congestive cardiac failure. The two most important use of digoxin in cardiology, useful for atrial fibrillation and for treatment of CCM. Now you should know how this drug useful for AF, how useful for CCM. Look at the mechanism action of digoxin as an anti-arrhythmic agent. This drug having vagomimetic property or vagomimetic action. See, we know vagus is a parasympathetic acting on myocardium on muscarinic receptor. We know M2 receptor in the myocardium at the AV node. So similar to vagus, my digoxin also acting on AV node like vagus, thereby reduces AV conduction. By reducing AV conduction, controlling heart rate, that property useful for treatment of arrhythmia. So digoxin having anti-arrhythmic action because of vagomimetic action, that be useful for AF and atrial flutter. But my topic is heart failure. In heart failure, how this is useful? Can you please answer, undergraduate? One common question for Viva. Can you please answer? What is the mechanism action of digoxin as an anti-failure drug? How this drug going to cause improving cardiac output? What is mechanism action? It's going, yes, good, ma, good. It's going to inhibit, good. Inhibit sodium, potassium, ATPase pump. Fantastic response. So digoxin acting by inhibiting sodium, potassium pump, thereby accumulating intracellular calcium. Come on. When the calcium accumulated, calcium causing muscle contraction, though, so increasing force of cardiac contraction. Because of that, cardiac output get increases. Now tell me, because of increased cardiac output, digoxin useful for treatment of low output CCM. So digoxin, a wonderful drug for treatment of low output CCM because of increasing force of contraction. Next. Another important drug is dopamine. This is what very important, even for undergraduate and postgraduate, very important. Dopamine is a very interesting drug in cardiology. Look here. Actually, dopamine is an endogenous catecholamine, but we have this as a drug in ICCU. This drug having 3 different actions. We have D1 action, beta 1 action, alpha 1 action, 3 actions. These actions are dependent upon dose. For example, if I give dopamine less than 2 microgram per kg body weight, it acts on D1. Come on. The D1 are seen on renal blood vessels, thereby causing renal vasodilatation. By dilating renal vessel, the dopamine going to improve renal blood flow. By improving renal blood flow, they're going to increase urine output. So improving kidney function. And when I give 2 to 5 micro per kg body weight, it acts on D1 and beta 1. The beta 1 seen on the heart. By acting on beta 1, improving force of contraction. By improving force of contraction, improve cardiac outputs. One more thing, when I give more than 5 micro per kg body weight, acting on all the D1, beta 1, alpha 1. The alpha 1 see on blood vessel, causing vasoconstriction, thereby improving blood pressure. So, in a cardiogenic shock patient, there will be hypotension, there will be poor cardiac output, there will be oliguria. So, remember, a cardiogenic shock patient with oliguria, the drug of choice is dopamine. Very important. Cardiogenic shock with oliguria, the important drug of choice is dopamine. Very important. And then we have one more drug called phosphodiesterase 3 blocker. Actually, we have ambrin, milrinone. These drugs are not in use. They cause so many problems, so we don't use this in practice. PD3 blocker, phosphodiesterase 3 blockers are there. Now, some drugs are there like ambrinon, is also called enambrinon. One more drug, milrin. The ambrinon causing severe thrombocytopenia and milrin causing severe arrhythmia. So they are not in use. Actually, they call ionodilator. Iono mean ionotropic. Dilator mean they also cause vasodilatory reaction. Thereby they call ionodilator, but they're not in use. But one question for undergraduate, very important question. Anybody? I have something called calcium sensitizer. Calcium sensitizer. Can you please answer? Name one calcium sensitizer also having PDE3 blocking property. Answer is yes, fantastic. Malaviga, Umesh, very good. It is levosimendan. Very fantastic. Good, good, good. Very good, Sanju. Wow, all are doing very good job. Very good. So we have one thing called levosimendan. Actually, it's a calcium sensitizer, but also having PDE3 blocking property. That's about new points. Okay. Next, this is what you need. Come on, undergraduate, postgraduate, you must know point, you must know point. Latest point in the field of treatment of heart failure, recent advance, very important point. Look here. When you talk about heart failure, today we are going to discuss one thing called vasopeptide. Actually, there are three important vasopeptide naturally we have in the body. One is called ANP. ANP means atrial natriuretic peptide. One more thing, BNP, called brain natriuretic peptide. One more thing, urodilatate. This is not that much important. Now, today topic, concentrator ANP and BNP. These are two important naturally available peptides. These peptides having three important physiological actions. The actions are, they cause natrate. Natrate means sodium loss. Diuresis, water loss. And they are also having vasodilatory property, so physiology. But what I want to talk today, we have some synthetic analog of ANP, BNP. Can you please answer, man, one interesting question? Name one latest drug. That's called synthetic analog of ANP. I want one synthetic analog of ANP. That is called corperitide. Corperitide. It's an analog of ANP. Another very important, a synthetic analog. Good, good, Senthil Kumar, very good, very good. A synthetic analog of BNP, very, very famous drug called Nesritide. Nesritide. Senthil Kumar, very good, Dr. E. Senthil Kumar, fantastic. So we have ANP called corperitide, BNP called Nesritide. Just for completion, analog of urodilatate, we have ularitide. Got it. Now, one interesting question you must know. The Nesritide is a very, very, very famous drug. So I will explain a little bit about Nesritide. Look up. Nesritide, we know a synthetic analog of BNP. That means this drug having same action. So what the pharmacological actions of this drug? The Nesritide also causes diuresis, water loss, natriuresis, sodium loss, and also causing vasodilatation. Now look here. Because of causing diuresis, all the lung edema getting decreases. And because of natriuresis and vasodilation, they are reducing preload and afterload heart. Because of this action, this is a wonderful drug for treatment of congestive cardiac failure. That's the latest drug. But interesting question, look at the pharmacokinetic. This is what very important. Kinetic is very important. Look here. Nesritide, actually an analog of BNP, P, brain natriuretic peptide. Since a peptide, it is not given orally. Come on, not given orally. This is what important. It is given only intravenous infusion. And this drug also having rapidly undergo metabolism by vasopeptidase enzyme. The vasopeptidase enzyme also called as neprilysin enzyme. Also called neutral endopeptidase. Remember. So the drug is rapidly undergo inactivation by neprilysin enzyme. There will be short half-life, acting only for less than 20 minutes. Now, one last question to all people. Can you please answer? Nesritide, I told, having natriuretic, diuretic, and vasodilative. Because of this action, what may be the important side effect? What happened to BP, man? A drug causing sodium loss, water loss, vasodilation, causing what problem? They're going to cause severe hypotension. Severe hypotension. That's about necessitated pharmacology. Now, interesting question. Look here. We discussed that necessitated is a vasopeptide. It undergoes rapidly metabolism vasopeptidase. And we also know the vasopeptide is also called neprilysin, also called neutral endopeptidase. In this, I want to ask one latest point. Can you please answer? Postgraduates there, can you please answer? Name some selective neprilysin inhibitors. Can you please answer? Name some selective neprilysin inhibitor. Postgraduates, the answers are very good. We have something called sacubitril and icodotryl. Remember. Come on. Abraham, please watch. Look. We have sacubitril, icodotryl. These two drugs are selective neprilysin inhibitor. Very important. Okay. A special point today, the sacubitril, remember, sacubitril given along with the valsartan. In practice, given along with the valsartan. Look here, valsartan. Look here, losartan, valsartan, all are ARB. Angiotensin receptor blocker. Look here, sacubitril is a neprilysin inhibitor. Look at it's a neprilysin inhibitor. Valsartan is a ARB. Now we have today combination of valsartan, neprilysin in practice. It is called ARNI. AR mean angiotensin receptor. NI mean neprilysin. Both are inhibiting. So ARNI. So find out the ARNI. Tell me one ARNI mean. Think of combination of valsartan plus neprilysin, the sacubitril. Very famous drug, useful for heart failure. Okay. Another very important question I want to tell you. Look here. The sacubitril icodotryls are selective neprilysin blocker. But one latest point, we have some drug called omopatrolol, sampatrolol. What are they? They are inhibiting angiotensin converting enzyme as well as neprilysin. They call dual enzyme blocker. Omopatrolol, sampatrolol inhibiting both angiotensin converting enzyme as well as neprilysin enzyme. Okay, that's about dual. Because of inhibiting this enzyme, they may cause side effect of angioedema. That's important. Okay, that's about latest one. Other latest drugs are, we go for basic RAS pathway blocker. I think you know the renin blocker is beta blocker, and sometimes clonidine methyl dopa, and direct renin activity blockers are aliskiren. Latest direct renin blocker. See, beta blocker reducing release of renin. Block beta blocker, whereas direct renin antagonist aliskiren, remikiren, inakiren are under trial, not yet marketed. Okay, then I think the basics. AC inhibitor, you know, any drug name ending with the pril are called AC inhibitor. Very important, and they are useful vasodilator. They're dilating both artery and vein. Arterio, we know dilator, so useful for hypertension, heart failure, useful for MI patient, diabetic. In diabetic, they having nephroprotective property, useful to control proteinuria, and also plays a major role in scleroderma crisis to prevent renal vasospasm, all these things. And then this is what important. The common adverse effect is they're going to accumulate bradykinin. Because of this, they causes angioedema and dry cough. Because of accumulation of bradykinin, they cause dry cough and angioedema. That's important. And here, one question for undergraduate. Can you please answer? ACE inhibitor by accumulating bradykinin causing dry cough, angioedema. So, can you please answer? Name one bradykinin antagonist. Yes, good. It's icatibant. Very good, very good. Icatibant, ICA. Icatibant is a bradykinin antagonist, useful to control cough, angioedema. Very good, Devi Kala. Very good, ma'am. Okay. Next is the contraindication. This is what very important. Come on. Since undergrad is there, I'm going some basics also. AC inhibitors are absolutely unsafe in bilateral renal stenosis in pregnancy. They are teratogenicity, causing fetal renal and pulmonary agenesis, and they are also causing hyperkalemia. So unsafe in hyperkalemic case also. Okay. And coming to ARB. When you talk about angiotensin receptor blocker, see, angiotensin 2 going to act on two important receptors, namely AT1, AT2. When we say ARB, I mean angiotensin receptor blocker. Mean mostly we are going to talk about AT1 blocker. Most of the drugs are blocking AT1 receptor. For example, drug name ending with the sartan, losartan, valsartan, irbesartan, telmisartan. Here I will tell one interesting points. Look here. All these drugs are vasodilator. So same use that of AC inhibitor, like hypertension, MI, heart failure, all the same use. And one more point, the advantage when we talk about ADR, these drugs do not cause no angioedema, because they do not interfere bradykinin metabolism. That's advantage. But they also unsafe in pregnancy, unsafe in bilateral hematosis, and unsafe in hyperkalemia. Same thing. Only one thing, on comparison to this meter, advantage, no cough, no angina. But that's all. Now coming to extra point, come on for postgraduate extra point. Look here. Losartan having two important special points. The points are it has uric action and thromboxylate to anticancer action, thereby preferred in gout patient, because uric acid preferred in gout. Because of thromboxylate anticancer, it has antiplatelet activity also. And then coming to valsartan, very special. Valsartan succubital called ARNI, useful for CCA, very important. Once again. So we're having valsartan plus succubital called ARNI. Next is very important. Telmisartan, very important. Telmisartan having PPAR gamma agonistic action. PPAR means peroxisome proliferated activated receptor gamma. This is going to cause insulin sensitization, thereby controlling diabetes. This is what very important. Name the ARB having anti-diabetic action mean telmisartan. Now the question goes to undergraduate. Come on, doctor. If the endocrine part was over, main, can you please answer? Name one anti-diabetic drug acting as a PPAR gamma agonist. Can you please answer? What is the original anti-diabetic drug controlling blood sugar by activating PPAR gamma? PPAR gamma. Answer? Yes, very good. Pioglitazone. Very good. So losartan having pioglitazone like activity, useful for treatment of diabetes also. Then olmesartan, candesartan is a prodrug. And finally, irbesartan. This is useful for treatment of atrial fibrillation with heart failure. So irbesartan useful for treatment of AF with heart failure. That's a recent advancements. And then finally we go aldosterone antagonist like spironolactone and active metabolite called candrenin. Candrenin is active metabolite of spironolactone. And then we go eplerenone, drospirenone. The spironolactone is very important. Potassium sparing diuretic. What is sparing diuretic? Useful for treating heart failure. And these drugs are causing hyperkalemia. So when you go along with this meter, there's a risk of severe hyperkalemia. Whenever you give potassium sparing diuretic with any RAS pathway blocker, risk of severe hyperkalemia, be careful. And finally, some more new points. See, we know sodium potassium ATPase pump inhibitor name is digoxin. We know. Similar to digoxin, we have one latest drug called hystaroxime. It is also having sodium potassium ATPase pump blocking property. Another newer drug is omecamtiv mecarbil. Come on. Yeah, another latest drug useful for CCF is omecamtiv mecarbil. It's a direct myosin activator, thereby improving force of contraction. It's called positive inotropic agent. And one more new drug is calcium sensitizer like pimobendan and levosimendan. This I told already. Levosimendan has extra PDE3 blocking property also. Okay. Another latest point, serelaxin. Is a drug having nitric oxide releasing property. It's a relaxing analog useful for heart failure, acting by releasing nitric oxide. That finishes all the newer drug useful for heart failure. Now, in summary, look here. For acute failure, acute heart failure, go for diuretic like furosemide, and then dilator, vasodilator, and then go for something called inotropic like digoxin, dopamine, or dobutamine. Whereas coming to heart chronic failure, disease modifying drug. That's called ROS pathway blocker. ROS pathway blocker. So important drugs are ACE-beta, ARB, beta blocker, aldose antagonist, spironolactone. And then one more point, look at this. Ivabradine, we discussed already. It's a funny current sodium channel blocker. Funny current sodium channel blocker. It's useful for treatment of angina as well as useful for CCF. Okay. Here, just to 2 points I want to tell. Look here. When we talk about ARB, I told valsartan plus sacubitril. Latest point you should know. It is called ARNI, angiotensin receptor and neprilysin inhibitor. And this is what very tough question, doctor. Beta blocker useful for CCF. I mean, you should know what are all the important beta blocker useful for CCF. For example, we have carvedilol, bisoprolol, metoprolol, and nebivolol. These are the FDA approved beta blocker useful for CCF. Here, one very interesting point, what you should know, beta blocker causes negative inotropic action and negative chronotrophy action. So be careful. They are unsafe in acute heart failure. Because of negative force of contraction, they will further worsen cardiac output. So problem. So they're very good for chronic failure. That too, in chronic failure, you should follow some procedure. That is, start with the low dose. Gradually upgrade the dose to the optimal level. So start with the low dose and gradually increase the dose. Okay. And if there's severe failure, don't use beta blocker. Stabilize the patient first by using diuretic and then go for beta blocker. That's the concept. And finally, one more thing. In African American population, these drugs also useful for CCF. For example, combination of isosorbate dinitrate plus hydrolysin is also approved for treatment of CCF in African American population. In Indian population, mainly we go for ROS pathway blocker for Indians. African American are responding well to ISDN and hydrolysin combination. That finishes another mega topic called heart failure. And then simple topic called anti-hypertensive. Why I say simple topic? For understanding hypertension, you should have knowledge on ANS, alpha blocker, beta blocker, all these things. You know, this simple. Okay. So just to one slide, I just make summary. When you talk about anti-hypertensive drug, we have head-to-foot drugs are there. For example, drug acting on CNS will be centrally acting alpha 2 agonist like clonidine, methyl-dopa, like rilmenidine, moxonidine, and even beta blocker also acting on CNS, reducing the vasomotor outflow. That's one thing. Second thing, drug acting on myocardium. There are some drug going depresses the cardiac output. For example, beta blocker and some CCB like verapamil, diltiazem, even nifedipine, all the dipines, dihydropyridine. Okay, and then vasodilator. Here you should know, if I say vasodilator, some drugs are predominantly dilating artery, some drugs are predominating vein, some are both arterio-venodilator. For example, look here. The neprilysin blocker like ANP, BNP analogs are mainly dilating venous system and also dilating artery. Whereas, look at this, the calcium channel blocker, ARB, alpha 1 blocker, potassium channel opener like hydrolysis, they are all maximally they dilating artery. Whereas some drug having both arterio-venodilatation, equally dilating artery and vein. For example, sodium nitroprusside and ACE-beta, even alpha blocker, non-selective alpha blocker like phenoxybenzamine, phentolamine, they have arterio-venodilating property. Other than vasodilator, drugs acting on kidney. When you say drug acting on kidney, mean ROS pathway blocker, renin inhibitors, and ACE-beta, ARB, all those antagonists like that. And then a drug acting on renal blood vessel, it's called D1 agonist called phenolidopam. Very important. It's a D1 agonist, very important renal vasodilator, useful for hypertension emergency drug named phenolidopam, a D1 agonist. So in general, when you talk about anti-hypertensive, you should know BP is equal to cardiac output multiplied by peripheral resistance. So if you reduce the cardiac output, if you reduces peripheral resistance, BP can be controlled. Based on this, I discuss what are all the important classes of antihypertensive drug. In addition to that, general advice, ask them to take salt restricted diet because sodium going to increase vasoconstriction, going to increase blood pressure. So sodium load should be reduced. Salt restriction diet and proper walking, lifestyle modification important for controlling blood pressure. In this junction, you should know as an undergraduate, you should know choosing a appropriate drug. For example, I show just one or two example. Hypertension with diabetes. Can you please answer, doctor? We have lot and lot of anti-hypertensive drugs like ACMETA, ARB, beta blocker, lot of drugs are there. Can you choose, man? A patient having hypertension with diabetes. For him, which is the best? Very good, Dr. Sachin. Very good. Best is ACMETA or ARB. Look at hypertension with the diabetes mean always your first line choice will be go for ACMETA or ARB. If not, next option CCB. But be careful while using beta blocker or thiazide diuretic. Look here, thiazide diuretic, beta blocker, they may cause hyperglycemia. So they worsen diabetes. So they're not good. So for treating hypertension with diabetes mean better go for ACMETA or ARB or CCB, but don't go for non-selective beta blocker or thiazide. Like that, how to choose the appropriate anti-hypertensive. That's very important. You have to study. Okay. And finally, hypertension with the hyperlipidemia. Here, best choice will be again ACMETA or ARB, or we can go for alpha blocker. They have favorable effect on lipid profile. Can you please answer now? Name some anti-hypertensive drug. Anti-hypertensive drug which have unfavorable effect on lipid profile, so that they are not good. For example, we have diuretic and beta blocker. The diuretic, thiazide diuretic and beta blocker, they have unfavorable effect on cholesterol, so they're not good choice. Okay, like that you have to study how to choose the appropriate antihypertensive. One more point, doctor. When you talk about treatment for hypertension, okay, we have one thing called JNC, Joint National Committee Guideline. According to JNC 8 guidelines, what are the first line drugs for hypertension? One, the first line drug useful for treating hypertension are thiazide diuretic, and then we have ACE inhibitors, then we have ARBs, and then CCB. These are the first line drug. Okay. Remember, beta blocker, alpha blockers are not a first line choice. Remember, in general, the first line antihypertensives are thiazide, ACMETA, ARB, and CCB. And finally, one more point, you should know what are all the important drugs useful for treatment of hypertensive emergency. When very high BP with the organ damage, end organ damage, emergency. For that, what drug can be useful? For example, hydrolysin, a potassium operator, esmolol, a ultra short-acting beta blocker, labetalol, a beta plus alpha blocker, enalapril, a active form of enalapril, nitroprusside, a nitrate derivative, and then CCB like nicardipine, clevidipine, and phenoldiazepam, a D1 agonist. So remember, Helen, H-E-L-E-N, dance, Helen dance. H for hydrolysin, E for esmolol, L for labetalol, T for enalapril, N for we having nitroprusside, D for dihydropyridine, like nicardipine, clevidipine. Extra one drug you add phenoldiazepam, that's a D1 agonist. All are useful for treatment of hypertensive emergency. So we finished the 4 important topics, namely angina, MI, next arrhythmias, next heart failure, next hypertension. Final topic, when we talk about MI, we need recanalization by using thrombolysis, anticoagulant, antiplatelet. The last topic for discussion, one, we go for thrombolysis, blood chapter, because cardiovascular, when you say vascular, you should talk about blood also. So thrombolysis, look here. There are so many examples. Old drugs are we having streptokinase, urokinase, and newer drugs are we have something called TPA, tissue plasminogen activator, like altiplase, retiplase, tenetiplase, altiplase, retiplase, tenetiplase. In addition to that, we also have some more newer drug called alfimiprase and desmotiplase. Alfimiprase and desmotiplase, but they are under trial. It's not yet marketed. So under trial only. So the marketed drugs are we having altiplase, retiplase, trentiplase. One very special point, how these drugs are acting on. Look at all these drugs are plasminogen activator. Look at the physiology. Plasminogen is also called profibrinolysin. So my thrombolytic drugs are going to activate this into plasmin. Plasmin is a fibrinolysin. So a plasminogen become plasmin. A profibrinolysin become fibrinolysin. By being lysin, they're going to lysis the clot. Clot lysis. Okay. We call thrombolytic mechanism action. Based on mechanism action, very useful. Useful for mainly acute ST segment elevation MI. Acute MI. Remember, thrombolytic drugs are contraindicated in non-ST because of more complication. And then they are also useful for doing facilitated PTCA. While doing PTCA, that is enough for treating infections. Along with, we can also try thrombolysis, but bleeding is the problem. Be careful. One more thing, useful for acute pulmonary embolism. So the three most important uses useful for MI, and then PTCA and for pulmonary embolism. One more thing, they also can be useful for thrombotic stroke, useful for treating thrombotic stroke patient. But be careful, doctor. One of the most important adverse effect of all these drugs are causing severe bleeding. Sometimes they cause intracerebral hemorrhage. Very important, dangerous. Now my question goes to all my dear students. Come on, undergraduate. One simple question. Can you please answer? I'm telling that all the thrombolytic agent causing common adverse effect of bleeding. So to control the bleeding, I have some antidotes. Can you please answer? What are all the antidote available for treatment of thrombolytic overdose or thrombolytic toxicity? Can you please say one drug? Yes, fantastic, Lavanya, fantastic. It is called EACA, epsilon amino capric acid. Epsilon amino capric acid, and then we have tranexamic acid. One more thing, aprotanine, very important. The most specific antidote is epsilon amino capric acid. Other drugs are tranexamic acid and aprotanine. All are useful as an antidote for thrombolytic agent. That's called thrombolysis. Next. In addition to thrombolysis, we have discussed something about anticoagulant. There are something called orally given anticoagulant, something called parenterally given anticoagulant. The oral drug is old drug called warfarin. That you know very well. Warfarin is a orally given anticoagulant. This drug actually acting by inhibiting vitamin K epoxy reductase. The mechanism of action of warfarin acting by inhibiting vitamin K epoxide reductase. By inhibiting this enzyme, ultimately warfarin inhibits gamma carboxylation, of vitamin K dependent clotting factors. Thereby, the vitamin K dependent factor like 2, 7, 9, 10, they are not getting activated. So, ultimate point for huge level, warfarin acting by inhibiting 2, 7, 9, and 10. Vitamin K dependent clotting factors are inhibited by warfarin. So the clotting factor inhibited mean they cause anticoagulation. Now one question to all my UG students, can you please answer? I am telling warfarin inhibiting 2, 7, 9, 10. Can you please answer? Among these four factors, which factor first attacked by warfarin? 2, 7, 9, 10. Everything attacked. First attack is by, yeah, very good, Dr. KP. First is 7. Look at the half-life. When look at the half-life of vitamin K dependent factor, the factor number 7 having half-life of only 4 to 6 hours. A short half-life. So the first factor attacked warfarin is factor number 7. And then look at the factor 2. This having half-life about 70 hours. That means almost 3 days. So the last factor attacked warfarin is factor number 2. But one common practical point you should know. Look here. I am telling that warfarin inhibiting 2, 7, 9, 10. That means to attack all the four factors, warfarin averagely taking about 3 days. It takes 3 days. So the full action of warfarin will be seen only after 3 days of therapy. That means warfarin mainly useful for prophylactic purpose, not for acute, because it needs 3 days for the full action to develop. Okay. In this, for postgraduate, I want to ask one question. Super question. Come on, postgraduates, look here. We are discussing warfarin inhibiting 27910. But you have to know not only 27910, even protein C, protein S, come on, protein C, protein S also, protein C and protein S also, vitamin K dependent clotting factor. Here, most important point, the protein C having the normal action of proteins is inhibiting factor 5 and 7. Now, post-graduate answer me. Come on. When I give warfarin, my warfarin not only inhibiting 27910, my warfarin also going to inhibit protein C. When protein C inhibited, they're going to cause elevation of factor 5 and 8 level. That may cause problem of hypercoagulation and dermal necrosis. Look at the picture. They cause hypercoagulation and dermal necrosis. Very good, man. Very good. So my answer very good. So sometimes causing hypercoagulation, skin necrosis, and sometimes they cause purple toe syndrome. Purple toe due to ischemia, like a purple color toe, purple toe syndrome. This is due to inhibition of protein C. Okay, and finally go for adverse effect. I think simple mnemonic for undergraduate, warfarin adverse effect, put about today after attending the webinar. I want to study about warfarin. So when you want to remember the mnemonic, ADR, adverse effect, warfarin, mnemonic, about A for alopecia, B for bleeding, O for orally given drug causing GI toxicity, Q for urticaria, T for teratogenicity. Very important. Warfarin is the teratogen, unsafe in pregnancy. Very important. It causes Conradi syndrome. It causes fetal chondrodysplasia punctata. Warfarin unsafe in pregnancy. That point is important. And then important question: what does the antidote mean? Warfarin inhibiting vitamin K? No. So antidote is K1. Phytonadione is the specific antidote. Here one question: phytonadione antidote, I do understand, but this drug reducing INR, it takes about 24 hours to bring down the INR. I can't wait for 20 hours. My patient is bleeding like anything. That means my question: what is the immediate choice? Can you please answer? What is the immediate choice to control bleeding due to warfarin? I can give vitamin K, okay, but it takes 24 hours to bring down the INR value. I can't wait for 20 hours. Immediately, yes, good, Kirtana. We go for fresh frozen plasma. So, immediate choice to control bleeding due to warfarin is go for fresh frozen plasma. It's having all the vitamin K dependent clotting factors. Okay. Now I go for recent advancement. When you talk about latest point, oral drug warfarin, you know, other oral drugs are we having orally given direct 2A inhibitor. Oral given direct 10A blocker. This was latest point. Look here. The oral 2A blockers are we having Zymalagatron, one more drug, dabigatran. Zymalagatron, one more dabigatran. The Zymalagatron causes severe hepatotoxicity, so this is not in use. Not in use. So one and only oral direct 2A blocker what we having in the market is dabigatran. But this does also undergo renal route of excretion, so unsafe in kidney failure. Okay. Now, one tough question, man. One tough question. If you answer this, you are the best student in whole India. Starting from Delhi to Kanyakumari or Kashmir to Kerala, you are the best. Can you please answer? Any anticoagulant side effect is bleeding. Side is bleeding. My question is, dabigatran may cause bleeding. To control the adverse effect of dabigatran, I have an antidote. What is the antidote? Can you please answer? What is the antidote for dabigatran? Answer. It's a direct 2A block. Yes, fantastic. KP, very good. Edaruzumab, fantastic, fantastic. KP, very good. Edaruzumab. It's a newer drug. It's an antidote for direct 2A blocker like dabigatran. Okay. And coming to next latest one, direct 10A blocker, we have apixaban, rivaroxaban, edoxaban, and petrixaban. We have apixaban, rivaroxaban, edoxaban, and petrixaban. All these are direct 10A. Everything ending with suffix XABN. Okay, and they also causing side bleeding. For these drugs, we have an antidote that is called anti-alpha. Somebody mistaken in the chat box. Anti-alpha is antidote for direct 10A blocker, whereas this and for direct 2A blocker. That's important. And last point, actually today, one more latest point. See, idarucizumab antidote for dabigatran, antidote for this. But for this and for this, I have one common antidote. The common antidote is, look up. We have one common antidote that is called siraparentak. So please note, we have one more important called siraparentak. It's a common antidote for direct 2A and 10A blocker. Okay, and then we go for injectable. All drugs are we having antithrombin 3 activator like heparin and LMW. Heparin inhibiting 2A and 10A, that is and LMW mean low molecular heparin. They are enoxaparin, dalteparin, tinsaparin, and nadraparin. Everything end is parin because the derivative of heparin. Okay, and we have one more group of drug acting via antithrombin 3s. We have fondaparinus, idrabiotaparinus. They also mainly inhibiting factor 10A. And once again, for heparin, we have antidote called protamine sulfates obtained from what's called sea fish, and 1 mg of protamine able to analyze 100 units of heparin. And then for LM delegates, for fondaparinus, for idrabiotaparinus, there is no specific antidote. Whereas for idrabiotaparinus, we have one antidote that is called avidin. Avidin is antidote for idrabiotaparinus. Okay, and finally, new drug. This also come on. For heparin adverse event, also put the mnemonic ABOUT, simple mnemonic ABOUT. A for alopecia, B for bleeding, O for osteoporosis, very important. And U for urticaria, T for thrombocytopenia. It's called HIT, heparin induced thrombocytopenia. And heparin also having aldosterone antagonism property, thereby having risk of causing hyperkalemia. Heparin also causes hyperkalemia. Okay, and coming to next point, new point, direct 2A blocker and direct 10A blocker. What are the injectable drug? Direct 2A and 10A blocker. Come on. The direct 2A blockers are we having bivalent drug, hirudin, bivalirudin, leprodin. Monovalent drug, argatropan, malagadron. All these drugs are wonderful drug for treatment of HIT. For treatment of HIT. If the patient developed thrombocytopenia due to heparin, for them alternative choice is injectable direct thrombin blocker. Very good choice. Here one extra point: argatropan undergo excretion of bile, so it's safe in kidney failure. All other drugs are unsafe in kidney failure. Argatropan safe in kidney failure. And coming to latest direct 10A blocker, Mixaber is under trial, not yet marketed. That finishes something about never injectable anticoagulant. And finally, I'm going for antiplatelet. The old drug is aspirin. Look at the point. Aspirin, low dose aspirin. When it's a low dose, say 50 mg to 160 mg in low dose, aspirin selectively and irreversibly inhibiting COX-1 enzyme in the platelet, thereby inhibiting synthesis of thromboxane A2, thereby having antiplatelet activity. And next extra point, we have one more drug called desoxyben. Latest. Desoxyben, a newer drug. It is inhibiting thromboxane synthase enzyme, thereby inhibiting synthesis of thromboxane A2. So that means what? There are two important thromboxane A2 synthesis inhibitor. One is called low dose aspirin. One more drug, desoxyben. Here I want a lot of new point, latest point. That point is, look here. Thromboxane A2 causing clotting factor, platelet aggregation. To prevent this, we have something called thromboxane A2 receptor blocker. What are the thromboxane A2 receptor blocker? We have something called epitroban, celtroban, daltroban, losartan. All these are thromboxane A2 receptor blocker. In that, one famous drug is losartan. Look here. I told losartan ARB having anti-platelet action. That is because of having thromboxane A2 receptor blocking property. Okay. And finally, look here. There is one drug going to inhibit synthesis of thromboxane A2 as well as blocking thromboxane A2 receptor. That drug is picotamide. Picotamide inhibiting synthesis of thromboxane A2 as well as inhibiting thrombolytic receptor. We call picotamine. So the slide shows what are all the drug antagonizing thromboxane A2 activity. Just once again, every day class, doctor, every day, evening 5 to 10, I'm teaching class for the damn students. So every day staining my throat. That's why I very often drinking water. So don't mistake me. Sorry for the interference. Okay. And then what are the other antiplatelets? Apart from thromboxane A2 antagonists, we have lot and lot of newer drugs. What are they? There's some drug acting by blocking ADP receptor. That's called P2Y12 receptor. Some more drug acting by blocking glycoprotein 2B3A receptor. Some more drug acting by inhibiting PAR. PAR means protease activated receptors. Okay. Now you should know what are the P2Y12 blocking antiplatelets. Very important, very important. Please note, we have something called clopidogrel, prasugrel, ticagrelor, cangrelor. Very important. Please note, we have ticlopidin, clopidogrel, prasugrel, ticagrelor, gangrelor. All these are P2Y12 blocking antiplatelets. Here, first important point, the first three drugs, that is ticlopidin, clopidogrel, prasugrel are prodrug. Here, one very famous drug is clopidogrel. Come on, it's a very famous antiplatelet. I told it's a prodrug. This drug for the action needs activation. How this drug is activated? It is activated by help of CYP2C19 enzyme. This is important. Clopidogrel activated with help of CYP2C19 enzyme. Now my question starts. Can you please answer? Name one drug. Name any one drug specifically inhibiting CYP2C19, doctor. Can you please answer? Yes, fantastic. Omeprazole, very good. So, omeprazole, a proton pump inhibitor inhibiting CYP2C19. That means when you give omeprazole with the clopidogrel, omeprazole inhibiting this enzyme, thereby clopidogrel will not get activated. So, there's an interaction between omeprazole and clopidogrel is very important. Please note the point. So, clopidogrel undergo activation by CYP2C19. Next point. Among the P2Y12 blocker, please note the cangrelor given intravenous. Remaining drugs are oral drug, cangrelor intravenous. And then prasugrel shows better efficacy. Nowadays, they're telling comparing to clopidogrel, more efficacy with the prasugrel and ticagrelor. And last, one more point you should know. Among the P2Y12 blocker, the ticagrelor is a reversible. It's a reversible P2Y12 blocker. Other drugs are irreversible blocker. Okay, that's about P2Y12 blocker. Next, glycoprotein 2B3 blocker. What are all the antiplatelet acting by blocking GP2B3? They call abziximab, FT-fibertide, and tyrifibin. See, abziximab, important. It's a monoclonal antibody. So, question: a monoclonal antibody having anti-platelet action is abziximab. Other drugs are FT-fibertide and tyrifibin. All these drugs are given intravenous. So, they used only in hospitalized patient, in IC patient, not as a routine OP procedure. All are given intravenous. Okay. And finally, PAR1 blocker, protease activated receptor blocker. They call Orapaxar, etopaxar. Yeah, another latest orally given antiplatelet. So, Orapaxar, etopaxar, both are PAR1 blocker used as an antiplatelet. Okay. Now, you know thrombolytic, you know anticoagulant, you know antiplatelet. The last point is, look at the point. They call PVD, peripheral vascular disease. Look at here, there's a problem in the peripheral artery where the patient complaining of leg pain, that too complaining of pain on walking and the pain really on wrist. It is called intermittent claudication pain. So for treating this, I have some drug. For example, I have one drug called pentoxifylline. What is pentoxifylline? Actually a methylxanthine. It's a methylxanthine group of drug having vasodilatory action. This drug is a non-selective phosphodiesterase inhibitor. Here, one super important point, this drug having rheological property. This is one important. Rheology means making flexibility of RBC. When the RBC flexible, the RBC can run even in micro circulation and supply oxygen. So by making flexible RBC useful for PVD, that's called pentoxifylline, but causing side effect of severe nausea and vomiting. In this junction, I want to assess your knowledge in pharmacology. Can you please answer either UG or PG? Can you please answer? Name one latest drug that's a selective PDE3 blocker useful for PVD. Can you please answer? Name one selective PDE3 blocker useful. Very good, Naveen. Very good. It is silastazole. Very good. Very good, Naveen. Very good. Lavanya, good. Silastazole. Come on. Silastazole is selective PDE3 blocker having vasodilatory plus anti-platelet action useful for perivascular disease. Very important. Since it's a vasodilator, this drug may cause side effect of headache problem and also have a risk of arrhythmia problem. Okay. And then this drug contraindicated in a patient with congestive cardiac failure. That was what are the important drugs useful for treatment of peripheral vascular disease. Okay, doctor. So what sir has given, he asked me to talk about recent advancement in the treatment of cardiovascular disease. So I started from angina and then MI, and then I gone for arrhythmias, and then I gone for congestive cardiac failure, and then gone for hypertension. And then I gone for blood chapter where I discussed about thrombolytic agent, anticoagulant, and then antiplatelet. I think from basic to latest, whatever latest, everything I just tried and given within 2 hours time. I think I fulfill my presentation. I hope it's going to be very useful for you. And then if you have any time, if you have any doubts, it's time for solving your doubts. Can you please ask doubts? Sir, somebody asking, sir, does wait, go post one more doubt, ma. Yes, wait, sir, still morphine given. Yeah, morphine is a narcotic drug. Narcotic. So you should have license to have morphine in your hospital. So morphine is a very good choice. If you have license to have morphine in hospital, you can give. But usually, wait. Usually in our hospital, we give buprenorphine, yeah, mu agonist, kappa antagonist. That's the safest drug. So we can give morphine or we can give buprenorphine. Is an excellent drug for treatment of MI pain. Okay. So if you have license, you can go morphine, or else you go for buprenorphine. That's very good. But they cause nausea vomiting. So give along with the antiemetic like promethazine. Yes. Next doubt. Come on. I'm waiting for your doubts. At least 4 to 5 doubts, because I've taken a lot of pain to prepare everything. Pain is not, that's problem is giving within 2 hours. That's what. Okay. That's a within, everybody knows fine, but everything should be given within 2 hours. That's a great job. So the further I'm struggling. So you have to utilize me opportunity. So please ask doubts. I'm ready to solve the problem. Routine MI. What's IV? IV morphine. IV buprenorphine. A license mandatory. Usually the hospital will have a license, no problem. Okay, we go for buprenorphine. Come on. Ticagrelor was a reversible. Cangrelor is irreversible. Ticagrelor is a reversible. Cangrelor intravenous and irreversible. ST elation may mean we go for thrombolysis. Any doubts?
Sir, it was a fantastic.
Okay, no doubt mean I gone out to Dr.
No, sir. Actually, we will collect the doubts and post to you.
Okay, sir. No problem, sir. No problem,
It
sir.
was a fantastic session. 2 hours,
Okay, thank you.
2 hours went like 15 minutes actually. And it was like listening to a cardiologist. Thanks a lot, sir.
Thank you, sir. Thank you very much, sir. Thank you very much.
I just asked Dr. Pradeep to give word of thanks, sir. We'll collect and post the doubt to you, sir, please.
Okay, definitely, sir. Definitely. Thank you.
Good morning, everyone. It's my privilege to deliver the vote of thanks on behalf of the Department of Pharmacology, Annapurna Medical College and Hospital. I take this opportunity to thank our today's speaker, Dr. Tirunavukarasu, Professor and Head, Department of Pharmacology, Savitha Medical College, Chennai, for accepting our invitation in his busy schedule and for delivering the excellent presentation. I further express my gratitude to our chairman, Mr. J. Satish Kumar sir, our dean, Professor Dr. P. Shanmugam sir, Medical Superintendent, Professor Dr. Mohan sir, Vice Principal Madam, Professor Dr. Usha, Deputy Medical Superintendent, Professor Dr. Prasanna Babu sir, Controller of Examination, Professor Dr. P. M. Subramanian sir, Director of Academics, Professor Dr. Dhaneshekar sir, for their constant support and encouragement. I extend my sincere thanks to all the participants, faculties, students, and my colleagues for joining today's webinar and making this event successful. Last but not the least, I would like to thank the IT department for their technical support in organizing today's webinar. Thank you, one and all.
Thank you, sir. Thank you.
Some few last words. It was like real action movies. The energy you have is really excellent. The 2 hours of firing. Thanks a lot, sir.
Okay. Thank